Assalamualaikum and hi everyone. My name is Putri Anisha bint Rashid and my student ID is 2024214246. Today I'll be presenting the radiographic image evaluation of the AP lumbar for the MRD444 subject. Without further ado, let's begin with the table of contents. In this video, I will be sharing information on the following key areas. First, the anatomy of the AP lumbar spine, the criteria for correct positioning, scoliosis and lordotic curvature, the criteria for adequate exposure factors, the application of the placement method, and lastly, diagnostic acceptability. Let's start by looking at the anatomy of the AP lumbar spine. This is the anatomy of the AP lumbar radiograph. At the superior part of the image, we can see the first lumbar vertebra, followed by zygapophyseal joint, pars interarticularis, intervertebral disc, inferior articular process, lamina, and the lateral edge of the psoas muscle. We can also identify the spinous process, ilium, sacroiliac joint, sacrum, transverse process, pedicles, and the superior articular process. Now, let's move on to the positioning criteria for a correct AP lumbar projection. First, the psoas muscles should be clearly demonstrated on both sides of the spine. Second, the spinous processes must be aligned with the midline of the vertebral bodies. Third, the sacrum and coccyx should be centered within the inlet of the pelvis. Fourth, the distance between the spinous processes and the pedicles should be equal on both sides, indicating no rotation. Fifth, the intervertebral disc spaces should be open and the vertebral bodies should appear without distortion. Lastly, L4 or L5 should be at the center of the collimated field with clear visualization from T12 to the sacrum, including the sacroiliac joints and psoas muscles. Next, we are going to discuss how to detect rotation on an AP lumbar spine radiograph. To begin, we evaluate the symmetry by checking two main things. First, we have to evaluate the distance between each pedicles and the spinous process on the same vertebra. Second, we can also evaluate the distance between each sacroiliac joint and the spinous process. If the radiograph shows signs of rotation, the site with the greater distance between these structures is the site that is positioned closer to the form. This indicates that the patient was rotated toward that side. For example, let's take a look at radiograph A. This radiograph shows no rotation. Why? Because we can see that the distance between the pedicles and the spinous process are equal on both sides, suggesting the patient was properly aligned. Now, let's take a look at the radiograph B. In this image, we can clearly observe the rotation. The distance between the left pedicle and the spinous process is greater compared to the right side, indicating that the left side was closer to the form. This is also indicates the patient was rotated to the left. Moreover, the distance between the left sacroiliac joint and the spinous process is also greater than the right side, which further confirms that the patient was rotated to the left. For improvement, the patient should be rotated to the right until the mid-sagittal plane MSP is perpendicular to the image receptor. Let's look at how to distinguish rotation from scoliosis. In patients with spinal scoliosis, the lumbar vertebrae may appear rotated due to the lateral twisting of the spine. While severe scoliosis is usually obvious and not easily mistaken for rotation, subtle scoliotic changes can be more difficult to differentiate and may resemble patient rotation. There are a few key clues to help tell them apart. First, spinal alignment. In cases of true patient rotation, the long axis of the vertebral column remains straight. It does not deviate laterally. In contrast, scoliosis presents with a lateral deviation of the vertebral column, giving the spine a curved appearance. Second, pattern of rotation. With true rotation, the rotation of the lumbar vertebrae is typically caused by the twisting of the upper and lower torso, so the rotation appears more uniformly distributed. However, in scoliosis, the middle lumbar vertebrae may demonstrate rotation without corresponding upper or lower vertebral rotation. By analyzing this characteristic, we can more accurately distinguish between patient rotation and scoliosis on a radiograph. However, in scoliosis, the middle lumbar vertebrae may demonstrate rotation without corresponding upper or lower vertebral rotation. By analyzing these characteristics, we can more accurately distinguish between patient rotation and scoliosis on a radiograph. Now, let's discuss the importance of CR alignment with the intervertebral disc spaces in an AP lumbar spine projection. When the patient lies in the supine position with legs extended, the lumbar spine naturally maintains an exaggerated lordotic curvature. As a result, capturing an AP lumbar image in this position often leads to closed intervertebral disc spaces, especially at L4 and L5, and distorted vertebral bodies. This happens because of how the X-ray beams are directed at the disc spaces and vertebral bodies. To improve the image and achieve better alignment, we need to reduce the lumbar lordosis by flexing the knees and hips, allowing the lower back to rest flat against the table. This positioning helps straighten the lumbar spine, making the intervertebral disc spaces more parallel to the CR and the vertebral bodies more perpendicular to IR. Next, the effect of lumbar lordotic curvature. To assess how well the central ray aligns with the intervertebral disc spaces, we evaluate three key features on the radiograph. First, the openness of the intervertebral disc spaces from T12 through L3, the amount of foreshortening of the sacrum, and the distance between the sacrum and the symphysis pubis. If the lordotic curvature was adequately reduced, the T12 to L3 disc spaces are open, the sacrum will show less foreshortening, and the sacrum will be positioned closer to the symphysis pubis. However, if the lordotic curvature was not properly reduced, the result will be closed intervertebral disc spaces, a foreshortened sacrum, and the sacrum position farther away from the symphysis pubis. This evaluation helps determine whether proper positioning was achieved to align the lumbar spine for optimal imaging. Now, I'm going to discuss the criteria for determining adequate exposure factors for an AP lumbar radiograph. First, contrast, which is KBP. To assess contrast, we examine both thin and thick bony structures. For the thin structure is the bony cortical outline of the transverse process, while the thick structure is the bony cortical outline of the pedicles or spinous process. If both of these structures are clearly visible, it indicates that an appropriate KVP was used, providing sufficient contrast. Second, density, which is MAS. To evaluate density, we also look at both thin and thick structures, where the thin structure is the bony trabecular pattern of the transverse process and the thick structure is the bony trabecular pattern of the pedicles or spinous process. When both structures are visible with good detail, the MAS is considered adequate, ensuring proper image density. The radiograph shown is the example of the adequate exposure. In a correctly exposed radiograph, the VCO of both the thin structure, which is transverse process, and VCO of thick structure, pedicles or spinous process, can be seen, indicating adequate KVP use, whereas the BTP of both the thin structure, which is transverse process, and thick structure, which is the pedicles and the spinous process, is also visible, indicating adequate MAS use. Therefore, the radiograph shows optimal exposure and both KVP and MAS should be maintained. Is the example of a radiograph with incorrect exposure. For contrast, the VCO of the transverse process, which is the thin structure, is not visible, but the VCO of the pedicles or spinous process, which is the thick structure, is visible, so this indicates over-penetration. For density, the BTP of the transverse process, which is the thin structure, is not visible, but the BTP of the pedicles or spinous process, which is the thick structure, is visible, hence this suggests overexposure. So, this radiograph indicates excessive exposure, meaning the image is both overpenetrate and overexposed. Thus, the KVP should be reduced by 15%. Now, let's move on to the placement analysis. We will be analyzing this radiograph step by step using the placement method. P projection. This is AP projection of lumbar. This is lumbar because the entire lumbar from L1 to L5 and the intervertebral disc spaces are visualized in the radiograph. This is AP because the iliac wings are not superimposed and there is no lordotic curvature seen in the radiograph. Next is positioning. The positioning in this radiograph is correct because the distance between the pedicles and the spinous process is equal on both sides. Also, the distance between each sacroiliac joint and the spinous process is also equal on both sides. These findings indicate that the patient was not rotated, so no positioning improvement is needed. Next, alignment. The alignment between the X-ray tube and the patient cannot be determined because there is no four borders of collimation. The alignment between the X-ray tube and the image receptor cannot be determined because there is no four borders of collimation. Lastly, the alignment between the patient and the image receptor is incorrect. This is because the central structure and the borders of collimation is unequal laterally. The centering point for this radiograph cannot be determined due to the absence of four collimation borders. However, the standard centering point for an AP lumbar projection is at the level of L4 or L5, which is typically at the level of the iliac crest. For collimation, at the superior border, the structure that should be included is T11, T12, and the first lumbar vertebra. At lateral borders, structure that should be included is the sacroiliac joints, iliac wings, and the transverse process. At inferior border, structure that should be included is ilium, sacrum, and both sacroiliac joints. There is no evidence of radiation protection apparatus seen in this radiograph. Now, let's evaluate the exposure factors. The KVP is adequate for penetration and contrast because the thin structure, which is the BCO of the transverse process, can be seen, and the thick structure, which is the BCO pedicles or spinous process, can be seen. Whereas the MAS is also adequate for detail and density because the thin structure, which is the BTP of the transverse process, can be seen, and the thick structure, which is the BTP pedicles or spinous process, can be seen. Hence, both KVP and MAS must be maintained. Next is marker. There is no evidence of anatomical marker shown in this radiograph correctly placed on right or left side of the firm and placed appropriately, not superimposing of any region of interest. Next, aesthetic. The firm size used is 35 times 43 centimeters, which is sufficient to demonstrate all structures of interest. And there is no evidence of any artifact shown in this radiograph. Next, name or identification. The patient's name, patient ID, date of examination, place of examination, and radiographer's name are not visualized on this radiograph at the appropriate area, not superimposing with region of interest. In conclusion, for diagnostic acceptability, this radiograph must be rejected due to no evidence of anatomical marker, patient and examination information are not visualized in the radiograph.
Before I end my presentation, I'm going to show you a few unacceptable radiographs due to its error positioning and exposure factors. For the first radiograph, it is unacceptable due to rotation. We can see the distance from the spinous process and the pedicles is not equal, meaning the right side has greater distance than the left. Thus, it indicates the right side of the patient is closer to the IR. Hence, the patient was rotated to the right side. To improve, the patient need to rotate to the left until MSP level is perpendicular to IR. For the next radiograph, it has a similar incorrect positioning with the first radiograph, meaning the right side is closer to the IR, thus indicating the patient was rotated to the right. For the last radiograph, we can see that it has incorrect exposure factors. Why? Because for contrast, we cannot see the BCO of thin structure, which is transverse process, but we can see the BCO of thick structure, which is pedicles. This indicates the radiograph is overpenetrate. Hence, the KVP need to be decreased to 15%. So, this is my list of references that I have used.
So, that concludes my discussion on the radiographic image evaluation for the AP lumbar spine. thank you all for your time and attention. See you next time. Goodbye.